Hello everybody, my name is Dr. Aisha Siddiqui and I am doing anesthesia residency from RNT Medical College, Udaipur. So I'll be discussing a few questions which are related to our daily anesthesia practice, which will help grow our anesthesia and critical care concepts a bit more stronger, and also it will help to, I think it will help to treat the patients in a little more aware and a better way. I'll be reading out the questions and all the 4 options that are related, and then we'll be discussing it. Also, I'll post the photos of the question in the group and on the channel as well. So the very first question is, you are called to assist a colleague who notes a large leak, that is a large gas leak in the anesthesia circuit. Very high oxygen flows, that is 15 liters per minute, are being used, but the ventilator bellows do not fill during the ventilator cycle. You then attempt to manually ventilate the patient, but the reservoir bag does not fill. You then disconnect the patient from anesthesia machine and attempt to ventilate the patient with an anesthesia bag that is connected to a separate oxygen source, but high oxygen flows are still required to achieve even a low positive pressure for ventilation. So the most appropriate step would be number A, to deflate the cuff and reinflate until there is a good seal. Number 2, pull out the nasogastric tube. Number 3 is to re-intubate the patient, and number D is to reconnect the endotracheal tube to the anesthesia machine circuit with 15 liters oxygen flow plus 15 liters flow of air. So I think this is a very practical question that is being asked, because normally in OTs it happens that we, even if after checking everything, even if after checking for all the errors, we encounter such problems. Okay, so what happens in anesthesia when we are inducing a patient, when the patient is not able to breathe on his own, that is breathing via the negative intrathoracic pressure inspiration and passive expiration, we take the patient on positive pressure ventilation, and then we ventilate him using our anesthesia machine that will include the delivery of the anesthetic gases as well as the oxygen to the patient, and passively when the patient will exhale out CO2, that CO2 will be absorbed, and then there will be a closed circuit. So what happens in our case, everything is going on very well, but then one of our friend has seen that there is some leak in anesthesia machine. Normally what happens is, when we when we perform a case, when there is a patient on the table, usually we are using very low flow, that is 2 liters or 3 liters or 1.5 liters of oxygen mixed along with the anesthesia gases that is being delivered, and in that the patient is maintaining very well. Okay, so not that much amount of oxygen flow is required in reality. So they are saying that very high oxygen flow, that is 15 liters per minute, is needed, and the ventilator bellows are not filling during the ventilator cycle. That means that there is some amount of leak. Now you have to imagine in your brain, you have to the ones who are working in the OTs, it will be a bit easier for them to imagine that the patient who is intubated and he is connected to anesthesia machine. So there is a ET tube, then the ET tube is connected to the connector is connected to the angle piece, which has a sampling line. It has an expiratory limb, inspiratory limb, and there's also an HME filter that is attached. Then the inspiratory limbs are connected to the machine end, and that machine end has the inspiratory valve and the expiratory valve, and there are check valves. Okay, so there can be leak in any of this part, because of which the oxygen is somewhere escaping from that leak, and because of that the patient is not able to, whatever we are setting, that set amount of oxygen is not delivered to the patient. Okay, the bellows are also not filling. Okay, so what happens? So now he has attempted to manually ventilate the patient. So he thought that maybe the automatic part of the machine, that is the bellows part of the machine, might not be working, might be faulty. So let me ventilate the patient on the anesthesia machine, but manually, using a manual bag that is attached to the anesthesia machine. But even after doing so, he ruled out that no, still nothing is proper. That means the bellows were not the issue, something else has the issue. So then what happens? Then what happens is, he attempts to ventilate the patient with an anesthesia bag that is connected to a separate oxygen source. So maybe with some Mapleson circuits, or maybe that is a Bain circuit. He has connected to some other oxygen source, and then he tried to ventilate, because now he's checking out if the oxygen supply is not proper, or if there is some problem inside in the anesthesia machine. But even after that, we see that there is very high flow that is required, and still the amount of positive pressure ventilation that is expected is not happening. So now what could be the reason? Why is it happening like that? Okay, so the first option is deflate the cuff and reinflate until there is a good seal. So let me tell you one thing, that seal is something related to prevent the aspiration of the contents in the trachea. The seal basically is, we are talking is the ET tube में जो seal होता है ना, cuff होता है, उसकी बात कर रहे हैं. तो if the vocal cord is very big, and as compared to that, if your ET tube size is small, and if you try to ventilate the patient, there will be leak. Okay, because the expiration and all, there will be expiratory leak more than the inspiratory leak also, because the ventilator, the larynx will have some empty spaces around, I mean the empty space, so from there the gases will leak. So first of all, there will be audible leak that you will be able to hear. You can palpate that amount of air that is passing, and it will not be as high oxygen flow. I mean the patient will be able, we will be able to ventilate, but there will be some amount of leak. And if there is something related to the seal, then the bellows will not fill. I mean these things are quite uncommon. Okay, next option is to pull out the nasogastric tube. So we'll discuss about it a little later. Next thing is to re-intubate the patient. So re-intubate the patient, the thing that they want to imply from this thing is the patient has been esophageally intubated. I mean the ET tube has gone into the esophagus. लेकिन अगर ऐसा होता, so you cannot achieve even the lowest amount of positive pressure ventilation. इसमें क्या है कि little bit of positive pressure ventilation is happening. That means somewhere or the other your tube is in the trachea, but it is not somewhere, something is not right. Okay, the next option is to reconnect the endotracheal tube to the anesthesia machine circuit with 15 liters of oxygen and 15 liters of air. So this makes no such sense, because ultimately you are increasing the FiO2 of the patient, because 15 liters of 100% oxygen you are giving, and 15 liters per minute of oxygen, that is the 21% of air, the 21% of oxygen in the air that we are giving. So I mean this is also not going to help you. What happens is, in the practical setup, while inserting the RT in an intubated patient, sometimes what happens, inadvertently, the RT, instead of going into the nasopharynx and the oropharynx, it goes from the nasopharynx inadvertently into the trachea. So for example, your ET tube was here, and there is some amount of space that is left, or maybe the cuff was little bit underinflated, and your RT has gone into the trachea. Okay, so now what happens, that whatever oxygen you are giving, there is amount of, you have created an open passage in trachea. Okay, so what you will notice, how you will figure it out that there is, the RT is in the trachea, you will see fogging in the RT also. Normally if we see fogging in the ET tube, we as anesthetists become so happy that okay, the ET tube is in place. But if we see fogging in the RT, really it is a very dangerous sign. Okay, so you might see some fogging in the RT, and if you connect the uro bag, you will see that the air is filling there. Okay, it has become inflated, the uro bag is inflated. In the initial steps, I mean this is quite sure that while inserting the RT, you have not confirmed, you have not palpated, you have not auscultated that the RT is in place or not. So what happens is, and obviously you're noticing huge leaks. So no matter if you ventilate through the Bain circuit, or you may ventilate mechanically, or you ventilate through the anesthesia machine, it will always show the leak, and it is so dangerous for the patient, because you are just wasting the resources. You're increasing the oxygen to 15 liters per minute, you're ventilating the patient, there is no set amount of tidal volume that is being reached, and also there is a lot of leak. This is very dangerous for the patient, and if ignored, it will lead to hypoxia. It can lead to a very, very dangerous side effect. So basically, if we pull out the nasogastric tube, the leaks will be settled, and there is no problem in the anesthesia machine. This is a very good question actually. This is ruling out what and all possible leaks are there, and this is practically very useful I found it very useful personally. I started observing the machine after reading this question, so I thought of sharing this with you guys. I want some reviews from you people, and we'll keep discussing such small questions. Okay, thank you.